Learning objectives is to an organized fashion ID and treat life threats. In an organized fashion, obtaining accurate history, perform an examination, and formulate diagnosis. Refine this diagnosis and this differential list over time and treat accordingly. Let's go into the respiratory anatomy. Now we know that there's the upper and lower airways, and so we need to differentiate between these type of medical emergencies. We know that without air entering into the bloodstream, we don't have that gas exchange. We're trying to get rid of carbon dioxide at the cellular level and then exchange it at the external respiratory cycle. This is controlled through the breathing apparatus, which is the large muscles of the diaphragm. It goes ahead and causes the air to come in and out of the respiratory anatomy. Regulation of this is controlled by sensors. These chemoreceptors monitor CO2 levels. For our COPD patients, it's the reverse, it's the hypoxic level. We do also change this pattern with the brainstem, and it is controlled through the apneustic pneumotaxis centers. Adequate breathing is measured by our tidal volume and breaths per minute, which will give us our minute volume. As we need to, we can increase the respiratory rate to blow off more CO2 or increase depth. Here we know that if the patient is in respiratory failure, we would see some sympathetic tone kick in, plus or minus, respiratory rate will either go up or down, and then we'll note that the hypoxia will start to develop and the patient become confused. Other signs of respiratory distress we should review as we go along. Let's review a first case using the AMLS assessment pathway. You have a 78-year-old male or a patient here, complains of shortness of breath. We want to look at how they're positioned. We want to get their general impression. We want to try to figure things out. Is there any other clues to see that we can use? Here we use our pathway as we go through the rest of the case. Now, as we enter the scene, we know that it's safe. We were wondering what kind of information did we get from dispatch? What do we see as we arrive on scene? Are there any other persons or personnel at the scene that can provide us history, knowing that they're short of breath and they won't be able to give us maybe a complete history because they can't breathe. Now we look and we see that the person is in mild distress, but with some normal mental status, increased work of breathing, and he's speaking maybe one or two sentences. Well, what do we think about the patient at this point? It does look like he may have some respiratory illness already, some chronic condition because he's on home oxygen. It does look older, so he may have some other chronic degenerative illnesses dealing with respiratory, but this could also mean that it could be another symptom or another system rather. So we need to start figuring out differential diagnosis based on the chief complaint of shortness of breath and being going on now for 4 days. As we get down, we look at the airway, breathing, circulation, and we know that there is some difficulty. Do we think that the patient has any life threats with his work of breathing? Can we treat any of those? Is the patient sick or not sick? What do we think our differential diagnosis would be? Most likely, we should be starting to think about some kind of respiratory illness. Is this an acute presentation or was this more insidious? And it looks like the person may have had some type of COPD, potentially pneumonia, but this could also be an acute exacerbation of a chronic illness, and then we could also be adding in a new onset acute illness that started within the 2-day time period. So now we can see that maybe there's an exacerbation of our COPD, maybe some pneumonia, maybe ARDS, and we would decide whether or not how sick our patient is, what's our likely diagnosis. We can start to refine this diagnosis by using our history and asking these questions. As we know that through the OPQRST and then our sample history. Now some of us, we decide to slightly deviate from either history taking, history of acute present illness using OPQST, or we may end up diving into medical conditions, health problems, and meds, and other practitioners may dive into looking at vital signs and doing more of a physical, and sometimes we do this simultaneously. As we're starting to learn how to do this, we want to grasp and understand that history is probably the first thing that we want to do of the present illness, sample history being second, and getting a detailed assessment in our secondary. We want to give these assignments away. So we're looking at a patient now that's in respiratory distress, pulse oxygen isn't that great, heart rate isn't that great, and it should be more tachycardic, respiratory rate is elevated, temperature doesn't seem to be normal. Does this mean that the person is not having an exacerbation of COPD? Is he having some kind of pneumonia and he's just unable to present with a fever at this time? As we do more of our physical exam, we're using the physical exam to sort of hone in and to dial in what we think really is going on with our patient. So we should be hearing something in the lung fields that would give us an idea of that. He's going to have some wheezing perhaps already. There's going to be some silentness in the respiratory lung fields because of the COPD in nature. Lung fields are longer, anterior posterior diameter, chest wall is changed. And so we may note these differences. So we would have a prolonged exhalation, short inspiration, and here we're showing that he does have some of these findings for our COPD. Here's some additional diagnostics to rule out that this and not something else isn't causing his shortness of breath, as it could be an ACS type case. And there we can take a look at the blood gas. So now let's take a look at this blood gas. This looks like we got a low pH, so we got an acidosis. Now look at our CO2, look at our bicarbonate, and we got a base excess here. White blood cell count is up as well, so we're looking at a respiratory acidosis with the CO2 being up, bicarb being low, trying to get rid of some of that acid, and we got a white blood cell that's up, so we know we got some kind of infection going on. Here's our 12 lead. We won't spend too much time on this. We don't see any P, S1, Q3, T3 in there, so no PE findings. We're not showing any acute ST elevations, so not MI. Don't show any kind of wide bundle branch block pattern, meaning that they could have some kind of respiratory condition. Now let's look at the bottom frame, which is showing us the end-tidal CO2, and we notice that that's that shark fin. Here's our X-ray that we're showing. We're showing a lot of white stuff, not a lot of darkness. What darkness would indicate that we're getting a lot of air movement and air exchange in the chest. So we go back to our differential treatments and we decide, well, where are we sitting on this and where do we go from here? What do you guys think is going to be our basic life support treatment? What would be our advanced life support treatment? What would be some critical care issues that we would be thinking about?